Assalamu alaikum warahmatullahi wabarakatuh, guys. Welcome back to the summary of standard medical textbooks, that is Harrison, Davidson, Oxford, Pocket Medicine, and so on. So we are on the way of discussing the cardinal symptoms of respiratory system. So in the last class we have discussed about the one more that's hemoptysis. In this class we will discuss about one more cardinal manifestation of respiratory system, that's pleural effusion. So let's begin. So first, beginning with the what is pleural effusion? Pleural effusion is the accumulation of serous fluid within the pleural space. So we can divide pleural effusion, to study pleural effusion, into two parts. One is general consideration and second one is specific consideration. General considerations include general causes of pleural effusion, and specific consideration include specific causes which discussing the specific causes which cause pleural effusion. So first, coming to the general causes of pleural effusion. So what's the pathophysiology? Number one is systemic factors, either due to increased pulmonary capillary wedge pressure, nothing but the hydrostatic pressure in the pulmonary capillaries, due to increase in the hydrostatic pressure in the pulmonary arteries, or due to decreased oncotic pressure, I think because of loss of proteins from the blood. There is decreased oncotic pressure, and we know that the formation of pleural fluid is dependent upon the Starling's forces, which we have learned in the physiology. Okay, lymph fluid or pleural fluid or pericardial fluid. So Starling forces act to balance the production of these fluids. So here there will be misbalance between this. So when there is increased hydrostatic pressure, example in cardiac failure, or decreased oncotic pressure, example in nephrotic syndrome, so there will be leakage of fluid from the blood vessels into the pleural cavity. Next cause is the increased microvascular pressure due to disease of the blood, that is due to inflammation of the pleura or injury in the adjacent lung. Disease of the pleura or injury to the adjacent lung. So that results in the leakage of fluid into the pleural cavity. So generally, when there is increased hydrostatic pressure or decreased oncotic pressure, the fluid is transudative. It is called transudative. It is transudative in nature, meaning it does not have pus cells, lymphocytes much. But when it is due to some disease or due to trauma, then it is exudative in nature, meaning it has pus cells, microorganisms, excessive lymphocytes, and etc. Next, coming to the causes of uh, pleural effusion. Let me zoom this. This will be very invisible to you, I think. So the causes of pleural effusion are: common causes include pneumonia. Pneumonia along with effusion is known as parapneumonic effusion or pneumonic effusion. Second common cause is tuberculosis. Third common cause is pulmonary infarction. Fourth is malignancy. Fifth is cardiac failure. Sixth is subdiaphragmatic disorders like subphrenic abscess, pancreatitis, etc. So these are the common causes of pleural effusion: pneumonia, tuberculosis, infarction, malignancy, cardiac failure, or subdiaphragmatic disorders. So these are nothing but cardiovascular and abdominal disorders which are contributing to pleural effusion. So uncommon causes include hypoproteinemia due to nephrotic syndrome, liver failure, or malnutrition, connective tissue diseases like SLE and rheumatoid arthritis, post myocardial infarction syndrome, that is also known as Dressler's syndrome. So there is also pericardial effusion. For Dressler's syndrome, yes. Then acute rheumatic fever, Meeks syndrome, nothing but ovarian tumor associated with pleural effusion, mixed edema, hypothyroidism, uremia, CKD in advanced stages of CKD, or in during the acute exacerbation of CKD. Then asbestos related benign pleural effusions in the form of pleural plaques, they will be usually in benign pleural effusions. Okay, these are the uncommon causes of uh, pleural effusion. Remember, in this, pulmonary infarction, cardiac failure, hypoproteinemia, either due to kidney or liver disease or malnutrition, connective tissue disorders, mixed edema, and uremia may cause bilateral effusions. And remember one thing, any systemic disorder usually causes bilateral effusion, and any localized disorder related to the lung, related to the heart, or related to subdiaphragmatic disorders will cause localized effusions. For example, if one lung has pneumonia, it will have sympneumatic effusion associated with that lung. If there is pancreatitis, there will be associated left-sided pleural effusion. If there is ascitic pleural effusion, then there will be associated right-sided pleural effusion along with that. So remember, whenever there is systemic disorder, when the disorder is systemic, or when that is that will usually cause bilateral pleural effusion, like in pulmonary infarction. Okay, so this is not systemic disorder, but it causes a bilateral a local disorder causing bilateral pleural effusion. Cardiac failure affects whole system of the body, so it causes bilateral pleural effusion. Hypoproteinemia is also systemic, either due to kidney, liver, or malnutrition. Connective tissue disease affects whole of the body, causes bilateral pleural effusion. Mixed edema, whole, and uremia, whole. So these can cause bilateral pleural effusion. Okay, so pulmonary infarction is a local disorder, but it can cause bilateral pleural effusion. Moving on to the next thing. So what are the clinical features of pleural effusion? What are the clinical features of the pleural effusion? Symptoms. So there will be pleuritic chest pain. What is that? Pain on inspiration and coughing, and signs of pleurisy. And on auscultation, you can hear a pleural rub, which precedes the development of an effusion, especially in patients with pneumonia, infarction, or connective tissue disease. You can have pleuritic pain in pneumonia, pulmonary infarction, and connective tissue disease. Okay. Second is, you can have breathlessness. So pleural effusion may be asymptomatic or manifest with dyspnea. Trypopnea is a very important symptom of pleural effusion. So dyspnea sensed while lying in one lateral position but not the other. Usually the patient feels breathlessness when the patient lies on the normal lung and the abnormal lung is on the upper side of the normal lung. So patient will say, I am having whenever I am lying on the normal chest, I am having breathlessness, and whenever I am lying on the abnormal chest, I am not having breathlessness. So patient doesn't know which lung is involved, but he will say, whenever I am lying down on one of the side, I am having dyspnea. Orthopnea, depending upon the underlying conditions. For example, in cardiac failure patients, underlying conditions and degree of effusion and degree of fluid accumulation, there can also be orthopnea. Okay, so pleuritic pain you can have in pneumonia, pulmonary infarction, and connective tissue disorder, and you can also have dyspnea, typically trypopnea, and also orthopnea in cases like acute left ventricular failure, or when there is increased fluid, both sides accumulation of uh, 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 high amount of fluid. So that's about the symptoms of pleural effusion, either pleuritic pain or breathlessness. Next one is signs. So when you examine, there will be asymmetric motion of chest, and there is impair that the motion of the chest is impaired on the side of effusion. When you percuss, it will be dull. There will be absent breath sounds in the setting. There will be absent breath sounds on the affected sides. In the setting of a small pleural effusion, pleural friction rub may be audible, and there can be displacement of mediastinum away from the side of effusion if the pleural effusion is large. Pleural effusion is large. So next, moving, so that's one type of classification of causes of pleural effusion: common causes and uncommon causes of pleural effusion. So depending upon whether it is transudate or exudate, we can have different causes of pleural effusion. Now we will discuss those causes. For first one is transudates. Most common cause is congestive heart failure, 40% of the time. 80% it is bilateral. Associated cardiomegaly on chest X-ray is a clue that it may be due to cardiac cause. The pleural effusion can be due to cardiac cause, especially. And if you want to confirm, you just give furosemide, and after furosemide, if the pulmonary edema is resolving, then the pleural effusion is usually due to cardiac failure. So that's how you confirm whether it is due to cardiac failure or not. Second is constrictive pericarditis. So there is something called as knocking sound which is heard on stethoscope in constrictive pericarditis. You can go and search on Google, and you can hear that sound. And when you image, there is calcification and thickening of the pericardium of the heart. This is most common cause of the transudate. The next common cause of transudate is cirrhosis, hepatic hydrothorax. So diaphragmatic pores allow passage of ascitic fluid, which is often right-sided 2/3 of the cases, and massive even without marked ascites. So without marked ascite, you can also have pleural effusion, usually on the right side when there is a patient of cirrhosis. So these two are the most common causes of transudative pleural effusion: heart failure and cirrhosis. Other causes include nephrotic syndrome, usually small, bilateral, asymptomatic. Rule out pulmonary embolism because there is hypercoagulability in these patients, in patients of nephrotic syndrome. Okay. Other causes of transudates include pulmonary embolism. Usually it is exudative in a pulmonary embolism, but it can be transudative also. Malignancy due to lymphatic obstruction. Hypothyroidism. Okay. Then coming to exudates. So what are the causes of exudative pleural effusion? Number one cause is infection of the lung parenchymal infection, 25% of the time. It can be bacterial or it can be mycobacterial. Okay, it can be fungal, viral. Okay, but the most common cause are bacterial and mycobacterial. Bacterial effusion is also known as synpneumonic effusion or parapneumonic effusion, and it evolves along a spectrum. So first of all, it is exudative but sterile, then it becomes infected and it becomes fibropurulent, then it causes fibrosis and formation of a rigid pleural peel, also known as fibrothorax. Common causes of lung parenchymal infection include Streptococcus pneumoniae, Staph aureus, Klebsiella, Pseudomonas, Haemophilus, Bacteroides, Streptococcus, mixed flora in aspiration pneumonia. So mycobacterial tuberculosis is also an important cause of exudative pleural effusion. More than 50% of time you will have lymphocytes, okay, 80% of the time. And important point is adenosine deaminase will be more than 40 will be more than 40, and it has a sensitivity of 80%. 80%. Okay. And most of the time when there is pleural effusion due to tuberculosis, you will not find this acid fast bacilli on staining, because it is findable only in 10% of cases when you stain it. So the most sensitive tests for tuberculosis to confirm that the effusion is due to that are ADA and pleural biopsy. More sensitive than ADA. Most sensitive is pleural biopsy. Okay, so these are the important infective causes of pleural effusion. Moving to the next cause, that is malignancy. So primary lung cancer is the most common cause. Metastasis from the regional structures are the second most common cause of pleural effusion. Okay, and they are exudative in nature, hemorrhagic. We will discuss later on. Moving forwards. So other causes include, like say, metastasis due to breast lymphoma, and other causes like mesothelioma. In that you have to check serum osteopontin levels, which are raised when there is mesothelioma, serum osteopontin levels. So the third most common cause of exudative pleural effusion is pulmonary embolism. It is effusions in 40% of when pulmonary embolisms will have effusions in 40, approximately half of the pulmonary embolism cases will have pleural effusions. And exudate is more common than transudate, and most of the time it is hemorrhagic. Must have high suspicion because the presentation is highly variable. Other causes include collagen vascular diseases like rheumatoid arthritis, large effusion, and SLE, small effusion, and granulomatous polyangiitis, which is a type of vasculitis. Okay, so rheumatological disorders and vasculitis are the fourth more common causes of this one, exudative pleural effusion. Then fifth common cause is abdominal diseases. Abdominal diseases which include pancreatitis, cholecystitis, esophageal rupture, and abdominal abscess. So these are the important transudative and exudative causes of pleural effusion. Transudative, just we will revise. Transudative is most common cause is cardiac failure. Second is hepatic hydrothorax, and you can also have in constrictive pericarditis, in nephrotic syndrome also. In exudative pleural effusion, number one cause is parenchymal infection of lung, can be due to bacterial or mycobacterium tuberculosis. And second common cause is malignancy, infection, malignancy. Then pulmonary embolism is the third common cause. Fourth is connective tissue disorder. Fifth is abdominal pathology. Okay, these are the 5 common causes of exudative pleural effusion in order. Now, what investigation will order? Remember the basic investigation. Whenever a patient comes to you with the pleural effusion, number one, whenever you are suspecting, you will do a chest X-ray and ultrasound, or ultrasound thorax. Next, if needed, in some cases it is not needed. If needed, then you will aspirate the fluid, pleural aspiration, and after aspiration, either it can be diagnostic or it can be therapeutic. So for diagnostic purposes, you will have ascitic fluid analysis along with gram staining, acid fast staining, cytology, and basically cytology with differential counts, and pleural fluid LDH, pleural fluid protein, pleural fluid protein and pleural fluid glucose. Pleural fluid glucose. Sometimes pleural fluid pH also. pH. So these are, and again, if needed, you will go third option for pleural biopsy. Pleural biopsy. Pleural biopsy. Pleural biopsy. Okay, this is the headings which we'll discuss further on. This will light scatter I will discuss. First, we will move on to chest X-ray. Okay. So whenever there is pleural effusion, the classical appearance of pleural fluid on erect PA chest film is of a curved shadow at the lung base, blunting the costophrenic angle and ascending towards the axilla. Fluid appears to track up the lateral chest wall. Previous scarring or adhesion in the pleural space can cause localized effusions. Pleural fluid localized below the lower lobe, subpulmonary pleural effusion, simulates an elevated hemidiaphragm, meaning it looks like elevated one-sided diaphragm. Pleural fluid localized within an oblique fissure may produce a rounded opacity that may be mistaken for a tumor. In the oblique fissure, it can produce a rounded opacity which can be mistaken for tumor. So we will see some chest X-ray. See here, this is the chest X-ray which is showing pleural effusion. So the costophrenic angle is gone. Okay, costophrenic angle is nothing but the angle between the ribs and the diaphragm. Okay, that is the first sign you need to see in cases of pleural effusion. And the fluid will track, it looks like tracking up to the axilla. This will be the typical appearance of fluid in cases of PA chest X-ray. Okay, in minimal cases you can just have the blunting of this costophrenic angle, maybe around 50 ml of fluid. If it is there, then you can have only blunting of this costophrenic angle. This much you will not have. Okay, so this picture you see here, there is a massive pleural effusion. And one more thing in this picture, here there is pleural effusion, and see the trachea is shifted to the opposite side. Here see, there is a massive pleural effusion, and along with trachea you can see shifting of the mediastinum also. The heart is also shifted towards the opposite side. This is a case of massive pleural effusion. This is a case of pleural effusion which is taken in a patient who is in lying down position. Same patient, when the chest X-ray is performed in upright position, see the fluid has come down and it is giving the appearance similar to this picture. So these are the appearance of pleural effusion. So you remember, there will be shifting of trachea to the opposite side, there will be blunting of costophrenic angle, and if massive, there will be shifting of mediastinum also. Moving forwards, see, this is one picture showing a D-shaped shadow in the left mid-zone, localized empyema, feature of localized empyema. Okay, consistent with an empyema. In this case, an intercostal chest vein has been inserted, but the loculated collection of pus remains because of the formation of septa. So that fluid is localized to that point. So this will be seen in chest X-ray when there is empyema. Now coming to chest ultrasound. It is more accurate than plain chest X-ray for determining the presence of fluid. So it can also differentiate between transudate and exudate. Clear hypoechoic space, it is transudate. Moving floating densities, it is exudate. And if there are septations, it can be evolving empyema or resolving hemothorax. That's why chest chest ultrasound is more superior than chest X-ray. It can differentiate between transudate, exudate, empyema, hemothorax. These all you can see. See here. Here there are septations and there are floating densities. So this is a case of this is a ultrasound of empyema. So see this in thoracoscopy, meaning opening the thorax surgically. So you see these septations formed in the pleural cavity. Okay, so this is fibrothorax. This is one more image which is showing septations in ultrasound. Okay, now coming to pleural aspiration and biopsy. So that is known as pleural aspiration or thoracocentesis. Ideally it should be ultrasound guided, but most of the times we don't use ultrasound and directly we from the in mid-clavicular line we insert that needle and take out wide bore needle and take out that fluid. Ultrasound guided. So what are the indications of aspirating the pleural fluid? All effusions which are more than 1 centimeter in decubitus view should be aspirated and should undergo pleural fluid analysis. If you suspect the pleural fluid is due to congestive heart failure, then just try to give furosemide and see if effusions resolve. Usually in 2 days, 75% of the effusions will resolve if these effusions are due to cardiac failure. So in that case, aspiration is not necessary if the effusions are due to cardiac failure. If there are atypical signs, in congestive heart failure, like if there is asymmetry of effusion, one side more, one side less, or if there is associated fever, associated chest pain, or failure to resolve even after giving furosemide injection, the effusion fails to resolve. In these 4 conditions, in these atypical features, you should aspirate the fluid and send it for investigations. So what are the 4 features? The 4 features are asymmetry, fever, chest pain, and failure to resolve even after giving diuretics. So these are the 4 features. Parapneumonic effusion should be tapped as soon as possible because you cannot exclude infection clinically, and most often these are unilateral. This can be bilateral also, but most often unilateral. Diagnostic studies which you do, first you will differentiate these things based upon the Lights criteria. So now we will move to the Lights criteria. Based upon the Lights criteria, first you will differentiate after aspirating the fluid into transudate or exudate. How will you differentiate? If the pleural fluid is likely, if one condition is met among these 3. So if pleural fluid protein a ratio to serum protein ratio, pleural fluid protein, PF protein to serum protein ratio is more than 0.5, then it is exudate. Pleural fluid LDH, serum LDH ratio more than 0.6 or PF LDH more than 2/3 of the upper limit of normal serum LDH. So any one of these criteria are met, then it is likely exudative pleural effusion. Protein and LDH levels are measured in serum and pleural fluid, and according to that you differentiate into exudate or transudate. Now further investigations, what will you do? So some main causes and their appearance. See here, if the cause is tuberculosis, usually it is serous, amber colored, Type of exudate is type of fluid is it is exudate. Lymphocytes predominate. Okay, so these are the features you will see in general features. General features you see in ascitic fluid analysis. Other features which you can do for confirming this tuberculosis is positive tuberculin test. It is diagnosed in children but not in adults. Okay, or isolation of MTB from pleural fluid, which is possible only in 20% of cases. That's why this is not much of value in diagnosing TB. Okay, so the more useful tests are pleural biopsy or raised adenosine deaminase. These two are the more useful tests to diagnose TB, for the confirmation of TB after obtaining this, if you don't have any other clinical feature. Okay, there are cutoffs we will discuss later on. If it is due to malignancy, it is serous, blood stained, again it is exudate. Okay, serosal cells and lymphocytes, and there will be clumps of malignant cells. Pleural biopsy is 40% sensitive only, and you can have evidence of malignancy elsewhere if it is a metastasis. Okay, Oxford says that if you do a second biopsy, then the sensitivity raises to 60 percentage. And if you are not finding finding a clue of malignancy, you have suspicion of malignancy, but you are not being confirmed by biopsy, then you can do thoracoscopy to confirm biopsy. In cardiac failure, obviously it will be a transudate, straw colored fluid, few serosal cells will be seen, there will be signs of cardiac failure, and there will be response to diuretics. Okay, in pulmonary infarction, it can be either serous or bloodstained. It can be serous also or bloodstained also in pulmonary embolism. It is mostly an exudate, rarely transudate. RBCs you can see in the fluid, and there will be evidence of pulmonary infarction in chest X-ray and CT scan. There will be source of pulmonary embolism like DVT, deep venous thrombosis, and there will be factors predisposing to venous thrombosis. For example, the patient is bedridden from so many days, or the patient had stroke in previous days. So these are the risk factors which you remember the Wells score. So Wells score risk factors the patient will have. Okay, so these are the features of pulmonary infarction. Next, rheumatoid disease, it is serous and exudative. Lymphocytes are predominant. In tuberculosis also you have lymphocytes. Okay, in malignancy also you have lymphocytes and malignant cells. Okay, remember this. Rheumatoid arthritis, anti-CCB antibodies and rheumatoid factor will be present, and in any chronic effusion there will be deposition of cholesterol. So there can be cholesterol in chronic infusion, and there will be very low glucose and pleural fluid, less than 60 milligram percentage. Remember this one. Okay, when there is SLE, again serous exudative lymphocytes. See, remember, see lymphocyte where and all you see lymphocytes in SLE, in rheumatoid disease, in malignancy, in tuberculosis, lymphocytes. Okay, signs of SLE, ANA will be positive, anti-DNA will be positive. In acute pancreatitis, either it can be serous or bloodstained like pulmonary embolism. Okay, it is an exudate. No cells predominate in acute pancreatitis, but there will be high amylase activity in the pleural fluid than in serum. So if you do amylase levels in the fluid level, they will be high compared to the serum in case of acute pancreatitis. Along with that, the patient will have history of chronic alcoholism and typical symptoms and signs of pancreatitis. If there is If there is obstruction of thoracic duct due to some lymphadenopathy or due to some tumor, then it will be milky chyle. It is also called as chylothorax. Type of fluid is chyle. No cells will predominate, and there will be chylomicrons. And see here, cholesterols. Okay, there will be chylomicrons, and cholesterol levels will be low here compared to because you will differentiate in next classes, otherwise it will become lengthy. Okay, so these are the features of some specific diseases. So Light's criteria, translate, exudate, and specific features. So what other diagnostic studies you will do? You will do total protein and LDH. From this you will know whether it is a transudate or exudate. Then you will do glucose. This is also very important. If glucose is less, either it can be infection, or it can be tuberculosis, or it can be rheumatoid arthritis. You will have cell count with differential count. So if neutrophils predominate, more neutrophils, it can be empyema. Okay, or it can be complicated syndemic effusion. And if lymphocytes are more, it can be tuberculosis, it can be malignancy, it can be uh, rheumatoid arthritis, it can be SLE. Okay, and if RBCs predominate, it can be pulmonary infarction. Okay, gram stain and culture you will do. Okay, pH you will do. There is importance of pH, will know forwards. Remaining fluid for additional studies as dictated by clinical scenario. So these studies you will do: protein, LDH, glucose, cell count, gram stain, culture, pH. What are the complications of pleural effusion? 5 to 10% of patients will have pneumothorax, and approximately 1% will have hemothorax, and re-expansion. Pneumothorax meaning effusion along with air. So hydropneumothorax they will have hydropneumothorax, and it is usually due to tapping of the ascitic fluid. So usually it is iatrogenic. So because of air and fluid, it will become hydropneumothorax. Okay, and hemothorax again because of tapping, there is injury, so there can be bleeding. That's why there is hemothorax. There can be re-expansion pulmonary edema. If you remove more than 1.5 liters of fluid is removed at a time, then there can be re-expansion pulmonary edema. Okay, and because of procedure, there is a chance of laceration of spleen if you don't do procedure uh, rightly, or laceration of liver. Post tapping chest X-ray not routinely needed. Okay, so these are all references which are given here. How do you decrease the chances of complications? How do you decrease the chances of complications? These complications with ultrasonography and experienced supervisor. Even with INR approximately 1.9 on patient direct um, anticoagulants, okay, like dabigatran, or what do you call apixaban, means factor 10 inhibitors, okay, or on clopidogrel, risk of bleeding is low with ultrasound and experienced operator. So that's why ultrasound guided tapping is recommended, which has very low chances of complications. Now, if the pH is low, less than 7.2, and glucose are less than 60 milligram percentage, then most commonly the cause can be infection, malignancy, and one more you remember, rheumatoid arthritis. Remember this one. Okay. Next. Now, in cytology, A single cytological test is only 50% sensitive for malignancy. A second sample increases the sensitivity to about 60%. Where cytology is negative, image-guided pleural cutting needle biopsy or thoracoscopy are the most sensitive techniques to identify the malignancy. 80% sensitivity. ADA activity, high activity, more than 40 to 70, strongly supports the diagnosis of tuberculosis in tuberculosis endemic regions like India. A low pleural fluid ADA level less than 40 effectively exclude tuberculous pleuritis in a low incidence setting. So where the tuberculosis is not endemic, if ADA levels are less than 40, then tuberculosis is excluded. And where the tuberculosis is endemic, ADA levels more than 40 are diagnostic. Alternatively, tuberculosis can be diagnosed by pleural biopsy. Closed biopsy has sensitivity of 80%, whereas thoracoscopy, meaning open and biopsy, that has sensitivity of 100%. So cytology will do and AD active will do. Next, if after doing all these, you don't know the reason for pleural effusion, so those are called as undiagnosed persistent pleural effusions. Okay, so what can be the cause? The most common causes, if it is transudative, will be congestive heart failure and hepatic hydrothorax. So there will be symptoms and signs of congestive heart failure or cirrhosis. We can do anti-pro-BNP of the pleural effusion fluid. Okay, and in exudative, the most common causes are malignancy, empyema, tuberculosis, pulmonary embolism. So which are the most, these are only the most common causes of exudative pleural effusion. So these are the most common causes of undiagnosed persistent pleural effusion. Okay, empyema, tuberculosis, malignancy, pulmonary embolism. How do you diagnose? Chest CT, ADA, IFN gamma releases say. IFN gamma releases say. Okay, or you can consider thoracoscopy also. So that's about the investigations of pleural effusion. Now coming to the treatment of general treatment of pleural effusion. So therapeutic aspiration may be required to reduce breathlessness, but removing more than 1.5 liter at a time is associated with a small risk of re-expansion pulmonary edema. Okay, therapeutic aspiration. Diagnostic aspiration is for diagnosis. Therapeutic aspiration is to palliate the symptoms. Along with aspiration, if needed, aspiration, treat the cause. The main thing is treat the cause, effusion will go off. And effusion should never be drained to dryness before establishing a diagnosis, as biopsy may be precluded until further fluid accumulates. So the main treatment is the treatment of underlying cause. So lastly, we will have the summary of generalized consideration of pleural effusion. See this one. So we will go one by one. So when there is pleural effusion, do thoracocentesis diagnostic, measure the protein level and LDH level to differentiate that into transudate or exudate Light's criteria. If protein ratio is more than 0.5 or LDH ratio is more than 0.6 or LDH is more than 2/3 upper normal serum limit, then it is exudate. If it is not, then it is transudate, and the common cause of transudate are heart, liver and kidney. Okay, exudate, now you know that it is exudate. Further things what you will do, if it is exudate, then you will measure the glucose. Okay, cytology, differential count, culture, staining along with acid fast staining, and PF marker for tuberculosis, which is nothing but ADA levels. Okay, so if the glucose is less than 60 milligram per deciliter, then consider malignancy, bacterial infections, and rheumatoid pruritus as the cause. If no diagnosis is, that is undiagnosed persistent pleural effusion. If the no diagnosis is established, consider pulmonary embolism, do a spiral CT or lung scan. If there is evidence of pulmonary embolism, then treat for pulmonary embolism. So first Harrison, this is from Harrison. So first rule out in undiagnosed persistent pleural effusion, rule out pulmonary embolism by doing chest CT, spiral CT. Second, PF marker for tuberculosis. Most specific is biopsy. So if there is evidence, treat for tuberculosis. If still the symptoms are not improving, observe the patient. Okay, if the symptoms are improving, then observe the patient. And if the symptoms are not improving, last thing which you do to diagnose a pleural effusion is thoracoscopy, either image guided or without image guided. Okay, it can be closed or open. So that's about all about pleural effusion. So this is the first part of pleural effusion. We will have the second part of pleural effusion considering the specific causes, specific common causes of pleural effusion in the next video. Do comment on the video how it was and what improvements should be done for this. We will do it inshallah. Thank you for your listening.